So it's my pleasure this morning to introduce my colleague, Mr. Muhammad Shahrun Nizam from the Department of Biomedical Imaging. Shahrun is a highly experienced lecturer at for more than 20 years with expertise in teaching academic programs and courses in medical physics. Over the years, he has trained medical physicists, radiologists, oncologists, radiographers, and biomedical engineers from universities, government agencies, and industry. His professional interests are primarily in CT, and he's also involved in research in nuclear medicine, psychophysics, and neurosciences. Throughout his career, Mr. Shahrun has contributed significantly at both national and international level. Among his key achievements, he served as consultant for the UNCIA, United Nations UNCIA, Global Survey of Medical Radiation Usage and Exposure under the Ministry of Health, and also principal investigator to several and co-investigator to several IAEA coordinated research projects. So today he will share with us his insight on computed tomography, CT, patient dosimetry, a topic that is crucial in balancing diagnostic image quality and radiation safety for patients. Over to you, Shahrun.
Thank you, Prof. Jeannie. Good morning. So this talk is about on physics. So I'll try to keep it the physics and math to a minimum. Basically, this is a review or a summary of the current situation for dosimetry in computed tomography. I think many of us are familiar with CT and CT scanners. These are some of the scanners that we have at UMMC. I would expect that the number of examinations today is much higher than what is stated on the screen. This is almost 500,000. This is in 2010. So we can assume that CT is very important in our healthcare system. And also, we need to be concerned of the dose to the patient. And we'll see in a while why that is. The first scanner in Malaysia was installed at Kuala Lumpur General Hospital in 1977. That is very soon after the first introduction in the early 70s. And we can see here how CT technology has changed and improved over the years. Why should we be concerned about those from CT scanners? Because there is a lot of studies which indicate that the scanning from X-rays can lead to the risk of cancer. And this is especially for children because they are biologically more sensitive to radiation. And this is not something new. This has been known for decades. And many efforts have been taken to reduce the dose to the patient through various methods. And there's a recent study, this is in April of this year, which claimed that 5% of all new cancer diagnoses would be related to CT. Right? So we can argue with the methodology or of the authors, or even their conclusion, but I think no one can deny that CT would have an effect or create a risk for cancer. An often cited principle is the ALARA principle, as low as reasonably achievable. So the idea is to balance between the benefits of CT imaging, we get all these good and nice images that helps us to diagnose patients. But we also know that there's a disadvantage in terms of the risk to cancer, right? So if you can lower the dose, patient radiation dose, this would lower also the risk to cancer. Usually when we state patient radiation dose, we don't really measure it directly. We measure it indirectly. There's no suitable method to measure it directly. And the often quoted quantity is known as the effective dose. This is a substitute quantity, an estimate of the whole body risk to cancer after radiation exposure. And there's also what we call organ doses, right? Which goes into the details for each organ. But usually what is often displayed, and we'll see later on, is the effective dose. A bit of physics. When we talk about exposure, usually the layperson will say that they come into contact with X-ray, for example. But technically, this would mean the ionization of specific volume of air. So this is the basis of all our patient radiation dose measurement. Right? So we can't measure it directly, so we compare the effect to air. This is the basic formulation to calculate effective dose in radiology for X-ray, right? Be it radiography, CT, or fluoroscopy. This is the basic formulation. So we got exposure there, and this is known as the absorbed dose. And through several steps, we take in all the different factors to come up with one single quantity, which is the effective dose. And this effective dose would give you a value of the risk, what are the percentages of risk to get cancer from a certain examination. When it comes to CT, this formulation is modified a bit. And the absorbed dose is now called CTDI. It's an index. And again, there are several steps before we get into effective dose. So the factor K here is a gross generalization of all the different factors. So they have all the different factors, and together they try to simulate and get the values for K. So a very good simple approximation of true effective dose within 10 to 15%. So the error there is quite high, so it's not truly accurate. And usually after the exam, after CT exam, you get the images. We will also get this information, which is the volume CTDI and the DLP, dose length product. So these two are often cited. So this represents the DLP represents the effective dose, while the CTDI represents the exposure. And these two are used to assess whether the dose to the patient is high or low. Right? So this is the current situation. But this is indeed unsatisfactory, and we will see why that is so. A bit of history, the physics, right? In the early days of CT scan, in the 70s, so it becomes widespread. Every hospital has one. So there need to be some standards to so that the quality would be maintained. Many studies have been done, so they come up with what is known as CT-DI. Okay, and this later on was adopted by the Food and Drug Administration of the US to become a standard for all the CT scanner manufacturer. And later on, as we've seen, the different steps is formulated to create the effective dose. Right? So initially, it was not meant as a measure of patient dose. It was meant as a standard to measure the output, the radiation output of the CT scanner. So where does this lead us after that, right? So before we go further into the future, perhaps we should go back into history and see where we start and where we're gonna head up, right? So multiple scan average dose. So the idea is that if you have several slices, CT scan, they give you slices of the body in terms of the image. So several slices. If you take the middle slice, this is going to be a combination, a cumulative input of all the dose from the different slices. So this forms the basis of the CT-DI, CT dose index. Right? So they did a little bit of math, right? And they say that you can now say that the MSID is equivalent to the CT-DI. Right? So the FDA adopted that, but with 14 slices, right? And it does not specify any material. So when we do this is theoretical. This is all theoretical, but when it comes to practical, we need something more tangible. So because it doesn't specify any material to be tested on, right? So we mentioned we got air, right? So it could be anything else. So the manufacturer then come up with the idea to use PMMA phantoms, right? So they proposed this to the FDA, and the FDA basically agree. So what we do now is to use PMMA phantom. One is 16 centimeter, another is 32 centimeter diameter, to simulate head and also torso. Right? And this is the scanning protocol. Right? Axial single slice, 10 millimeter congruous slices, and the dosimeter, the device used to measure, is the ion pencil chamber, 100 millimeter. So this is the scanning protocol proposed, accepted, and has been in use up until now from 1980. Okay, so that's almost there's 45 years. Right? So it's useful and practical. Right? So it makes the manufacturer easy to standardize the output. But later on, this is in 2007, there's a concern that CT-DI has served its purpose and is no longer useful. Right? Because the CT technology has improved so much, and there are various scanning protocols, scanning method for CT, which is very much different from the technique, the first technique here. Okay? So it is said that this cannot be comparable to the actual clinical CT scanning protocol. In short, they're saying that it's not clinically accurate. Again, remember that CTDI is not meant for a measure of patient dose. It is measure of the CT radiation output, the quantity of radiation given by the scanner. So it's not clinically accurate based on 10mm slices and axial, whereas almost all of our scanning today are helical using variable slice thickness. So a lot of compensation needs to be met if we were to use or base our patient dose on CT-DI. And also the size of the X-ray beam is also larger. Another issue is the use of the PMMA phantom. So you can see A and B, those are the head and body or torso phantom, right? So this is the one used for measuring CT-DI. There are better phantom, right, in terms of the geometry in C and D, right, and also F, which tries to simulate an actual body of a patient. But compare these to E, an actual patient, you can see how it is lacking, right? So again, this would add many errors and inaccuracies in the measurement, right? Again, if it's just to measure the output, fine, but it will not be sufficient as a measurement of patient dose. A lot of compensation, a lot of correction needs to be met. Another issue is the another iteration of the CTDI. We have weighted CTDI here. Previously, we mentioned CTDI 100. Right? So weighted CTDI, this is the equation, 1/3 of the CTDI in center plus 2/3 of the CTDI periphery, right? But there are claims that half plus half, right? Or even 3/8 plus 5/8 is more accurate. Again, the community, right, even though has accepted 1/3 or plus 2/3, and there doesn't seem to be any initiative to recheck the values used, right? And it is accepted as the truth, but it would be, I think, time for the CTI weighted formulation or equation to be revisited. So overall, in general, the medical physics community, right, doesn't really wants to rock the boat. Right? They want to change much. So only minor alternatives are given. Right? So for example, using CTDI with helical scanning, right? And then slight change to the type of phantom used. Okay. But again, these are academic studies and has not been used extensively in the for commercial purposes. Other type of corrections is the introduction of the SSDE, site-specific dose estimates. This came in 2011 to correct for patient size, right? So the phantom is circular in shape, in geometry. So our patient's or human body is more like an ellipse. So this has been brought up as a correction. And then 3 years later, an update, right, based on water equivalent diameter. Right? So these are attempts to make the patient dose estimate more accurate. Right? So in 2006, there's a question posed by a group of physicists, right? And this has been put into writing in the medical physics journal, whether we should retire the CTDI, right? And this is 2021, still true today, right? It seems that the community seems to have a liking to or is very familiar with CTDI, and everyone seems to agree that CTDI should not be changed, but perhaps modified to suit certain requirements, right? So what other alternative do we have, right? Direct measurement. Right? This is where we use the dosimeter in a phantom. It's more accurate, but not practical. We have mass patients. So when we have an exam is finished, and then we do a simulation using phantom. Right? This is one. And then you also have computational phantoms and dose databases. These are just some examples. Right? But this also rely some part of it in terms of the calibration of the model in terms of the radiation output to CTDI. So it's not totally unreliant on CTDI. There's some aspects of it still on CTDI. These are some examples which will do CT. Right? Again, these are done post-exam. Post-exam. NCICT is another. And then with the advent of hybrid imaging, we got PET-CT, SPECT-CT. There's also software which measure for both modality. So you have a complete assessment of the patient dose. So what can we expect from the future? Direct from patient CT images, meaning that when we do scanning, immediately after the exam is finished, the relevant dose, patient dose information is then provided. Right? This is just a preliminary endeavor, and hopefully this will be the future for CT dosimetry. This just come out in this year, 2025. Right? So it is real time. So in terms of the calibration of the or the measurement of the dose output, we still rely on CTDI, but that's a good thing. We put CTDI on where it should be used. And I think this is going to be the future, hoping that the manufacturer would take up on this with a push from the relevant medical physics organization. And that is all for me. Thank you very much for listening.
Thank you, Shahrun. Thank you for the crash course on CT dosimetry. Certainly, I think very interesting. It will be very interesting in future to be able to have real-time, personalized organ dose estimation from CT indeed. Okay. Any questions from, let me just check if there's any question from the floor. I don't see any. So maybe just one question from me, Shahrun.
Yeah.
Now, just now for the pediatric talk, they talk about databases. What do you think is, do we need CT data, those databases in Malaysia or worldwide?
There's many databases already on pediatrics, but what they have so far are not actual clinical data, right? So they basically have the data for the adult, and then from there, they recalculate it for the size of the pediatrics. I think we should have it. There are initiatives in a few places over the world which has organized where we can submit our own data. Right? These are basically done for the creation of a worldwide data, and then this will then be a new database for a new software. That's one of the aim. But I think maybe we should do for Malaysia also, right? Because we know that rather than having used data which may not be suitable for our Malaysian and Asian in general, we could have one which more suitable for us.
Agree with you, Shahrun. Thank you very much for the talk today. With that, I would like to, it's 9 o'clock, so I'd like to pass over the session to the admin, or we will end the session today. Thank you very much.